Okay, let's unpack this. Today we're diving into a topic that, well, it affects half the population, yet often feels shrouded in mystery or maybe dismissed.
Yeah.
Menopause. You've sent us a ton of information, really great stuff, and our mission today is to cut through the noise, look at the surprising science, and equip you with some truly well-informed insights.
Yeah, it's fascinating, isn't it? How much of menopause is this completely natural physiological transition, but its symptoms and, the long-term implications can be so varied, and they can significantly impact a woman's health. We'll explore the science behind these changes, really from the cellular level right up to the systemic impact. And we'll discuss both the physical and, importantly, the emotional landscape it creates.
Right, so we'll define exactly what menopause is, pinpoint when it generally happens, then take a tour through those incredible hormonal shifts. We'll look at how this impacts pretty much every part of the body, explore the common symptoms people experience, how they're diagnosed, and finally get into the different ways it can be managed, both with and without hormones. And definitely stick around because we'll uncover some surprising facts along the way that honestly might just change how you think about this really pivotal life stage. So let's start right at the beginning. What exactly is menopause? Is it really just a single moment in time?
That's a great place to start because, yeah, it's often misunderstood. So, menopause itself is defined as the permanent end of menstruation. And that happens because the ovaries basically stop releasing eggs and producing key hormones. But crucially, it is technically a point in time, that very last menstrual period you ever have.
Okay, the last one.
Exactly. But clinically, we can only really confirm it looking back retrospectively. So you need to have gone 12 consecutive months without a period, and we need to rule out any other, medical reasons for that pause.
Right, that makes perfect sense. So it's not like you just wake up one day and boom, menopausal. There's a lead up, right? Process. What do we call that phase?
Exactly right. That whole process leading up to it and even a bit after is called the menopause transition, or you'll often hear perimenopause. This period typically lasts about 4 to 7 years, kind of straddling that final menstrual period. And during this time, you'll start seeing hormonal changes like elevated FSH, that's follicle stimulating hormone, and LH, luteinizing hormone. These are the brain's signals to the ovaries.
Try to get them going.
Pretty much, yeah. And you'll also notice a lot of variability in your menstrual cycles. They might get longer or shorter, or you might skip periods altogether. Then, after that specific point of menopause, you enter postmenopause, and that's, well, the rest of your life.
Okay, that clarifies the timeline. Now, what about the age? That's another big question people have. Is it just random? Or are there factors that influence when it happens?
Good question. The average age is around 50 years old, typically falling somewhere between 45 and 55. But what often surprises people is that the timing is largely genetically predetermined.
Oh, really? So all those things you hear about.
Yeah, like when you started your periods or number of pregnancies, breastfeeding, using the pill, socioeconomic status, race, height, weight. The science says those don't really predict the age of menopause. It's mostly down to your genes.
Mostly. But are there any exceptions? Any factors that can shift it a bit?
There are a few. For instance, women who are thinner, so lower body mass index, might experience menopause a bit earlier. And certain lifestyle factors, definitely cigarette smoking and also severe malnutrition, can accelerate the onset.
Okay, so knowing all this, why is it so clinically important for you listening now to really understand this transition, especially since, people are living so much longer these days?
Oh, it's critically important. Because women are living longer, especially in, affluent societies, it means about 1/3 of a woman's life might now be spent postmenopause in a state of lower estrogen. And this isn't just about, hot flashes. This prolonged state of estrogen deficiency can lead to significant long-term health issues. Things like bone health, cardiovascular health.
Yeah.
It really impacts overall well-being.
Right, so understanding it is key to managing that long-term health.
Absolutely. It empowers you to be proactive.
Okay, so we know what it is when it generally happens, but let's get into the why. What's actually happening inside with the hormones? It sounds like a really complex hormonal ballet, as you said.
It really is. At the very core, it's all about the ovarian follicles, the tiny sacs in the ovaries that contain the eggs. Over many years, even starting well before you notice changes, these follicles gradually deplete in number. And the ones that are left become less responsive, kind of resistant to those brain signals, FSH and LH.
Okay. So the brain's yelling, but the ovaries aren't really hearing it as well.
That's a good way to put it. And because of that, there's a significant fall in the main type of estrogen, which is called estradiol. It can drop from levels of maybe 5,300 picograms per milliliter premenopause down to just 10-20 pgml postmenopause, a huge drop.
Wow, okay. And how does that big drop in estradiol affect the other hormones, like FSH and LH?
Well, estradiol normally tells the brain, okay, we've got enough estrogen, you can ease up on the signals. That's negative feedback. When estradiol drops so low, that feedback signal weakens. Plus, another hormone called inhibin, which also comes from the follicles and dampens FSH, diminishes. So without that negative feedback, the brain ramps up production. FSH levels skyrocket, rising maybe 10 to 20 times higher, and then LH follows, rising about threefold.
So the brain is really trying hard to stimulate those ovaries.
Exactly. But the ovaries just can't respond like they used to. This whole hormonal shift disturbs egg development, leads to cycles where no egg is released, or maybe ovulation happens irregularly. And ultimately, when there are basically no viable follicles left, estradiol drops below that critical threshold, around 20 pgml. That means the uterine lining doesn't get the signal to grow, and menstruation stops for good.
So it's not just that estrogen vanishes entirely, but the type of estrogen changes and where it comes from. You mentioned that. And what about other hormones like androgens, the male hormones?
Excellent point. Yeah. Postmenopause, the main estrogen circulating isn't estradiol anymore. It's a much less potent form called estradiol. And here's something really interesting. After menopause, your body fat, your adipose tissue, becomes a major production site for estrogen.
Really, fat tissue makes estrogen.
Well, it converts other hormones into estrone. Specifically, it converts androgens hormones like androstenedione that come mainly from your adrenal glands and still a bit from the ovaries. This conversion process is called aromatization. But remember, estrone is only about 1/10 as potent as estradiol was.
Okay, so the body's adapting, finding another way, even if it's a weaker version. And you mentioned true menopause. What happens then?
Right, so about 5 to 10 years after the final period, even these sources of androgen precursors start to decline further. That leads to an even sharper fall in all estrogens. That's sometimes referred to as true menopause. Now, regarding androgens, the stromal cells in the ovaries, the supportive tissue, actually keep producing some, like testosterone, partly because those LH levels are still high. However, the overall amount of androgens circulating in the body tends to be lower because quite a bit is being converted into that estrone we talked about.
So the balance shifts.
Right.
The ratio of estrogen to androgen changes. And that has effects.
Precisely. The net result is a decrease in the estrogen to androgen ratio. And this shift is what can lead to some of those physical changes people notice, like maybe more facial hair growth, or sometimes even slight deepening of the voice.
Interesting. And you mentioned obesity earlier. How does that play in?
Yeah, individuals with more adipose tissue, so those who are obese, tend to convert more androgens to estrone. This can sometimes mean they experience fewer symptoms of estrogen deficiency, like hot flashes, and might have a bit less osteoporosis. But the flip side is that higher estrogen level can increase the risk of other things, like the uterine lining thickening too much, endometrial hyperplasia, or even carcinoma.
Okay, so it's a complex balance. What about progesterone?
Postmenopause, progesterone levels are very low, just trace amounts, probably coming from the adrenal glands. And another hormone, anti-Mullerian hormone, or AMH, which is a marker of ovarian reserve, drops markedly.
Got it. So it's clear the hormones are undergoing this massive shift. But what does that actually mean for the physical structures, the organs themselves? This is where we can sort of visualize the changes.
Absolutely. Estrogen has such wide-ranging effects, so the changes are pretty widespread across the body. Internally, organs like the ovaries themselves shrink. They become kind of wrinkled and whitish. The uterus also gets smaller. The lining inside the uterus, the endometrium, becomes thin and atrophic, although in some women with higher estrogen levels, it might still show some growth. The cervix produces less mucus.
Okay. And what about changes that people might notice more directly, like in the vaginal area?
Right. The vaginal lining thins out considerably. It loses elasticity, and those natural folds, the rugae, flatten. There's also less glycogen, which normally feeds beneficial bacteria, so the vaginal pH becomes more alkaline. This can lead to dryness, making sex uncomfortable or painful. That's dyspareunia. It also makes the tissue more fragile, prone to tiny tears or bleeding with minimal trauma, and increases susceptibility to itching and infections. The external area, the vulva, also shows atrophy. The labia flatten, pubic hair might become scantier.
And I imagine the urinary system is affected too, given how close it is.
You're right. They share similar tissue origins. The lining of the bladder and urethra thins, just like the vagina. This can make you more prone to irritation, damage, and infection. So, symptoms like dysuria, painful urination urgency, needing to go frequently, and even recurrent urinary tract infections become more common.
And incontinence.
Yes. Stress incontinence leaking a bit when you cough, sneeze, or laugh can also worsen or appear. On top of that, there's often a general loss of muscle tone in the pelvic floor, which can contribute to things like the uterus descending slightly or changes around the bladder neck, potentially worsening any existing pelvic floor issues.
Okay. What about breasts?
Breasts change too. Fat tissue tends to get reabsorbed, the glandular tissue atrophies, the nipples might decrease in size, they can become flatter and more pendulous.
Well, it really does affect so many areas. Beyond these direct organ changes, let's zoom out to the bigger picture for long-term health. You mentioned bones and the heart earlier. Let's talk about those.
Yes, these are two critical areas where the loss of estrogen has profound long-term consequences. Let's start with bone health. After menopause, women typically experience accelerated bone loss, maybe around 3 to 5% of their bone mass per year for the first few years. This is directly due to estrogen deficiency.
3 to 5% per year. That sounds like a lot.
It is significant. This leads to osteoporosis, which is when the bone mass drops so low that the bones become brittle and much more likely to fracture. Before you get to osteoporosis, there's a stage called osteopenia, which is basically low bone mass, a warning sign. Think of your bones becoming less dense, more porous.
And this increases the risk of fractures, obviously. Which bones are most affected?
The most common sites for osteoporotic fractures are the vertebrae in the spine, the hip, specifically the femoral neck, and the wrist, what's often called a callus fracture.
So how exactly does estrogen protect bones? What's it doing?
Estrogen plays a really vital role. It primarily works by inhibiting the cells that break down bone. Those are called osteoclasts. Think of them as the demolition crew. Estrogen tells them to slow down. It also helps your intestines absorb more calcium from your diet, stimulates another hormone called calcitonin, which also inhibits bone breakdown, and influences vitamin D metabolism, all things that promote bone mineralization, making bones stronger.
Okay. And how is this diagnosed? How do you know if your bones are thinning?
The gold standard for diagnosis is a DIXI scan dual energy X-ray absorptiometry. It's a special type of X-ray that measures your bone mineral density very accurately. CT scans can also be used. Doctors also use a tool called FRAX, which calculates your estimated 10-year risk of having a major osteoporotic fracture based on your bone density and other risk factors.
What are some of those risk factors besides being postmenopausal?
Well, family history is a big one. Also, age over 65, being of Asian or white race, having a low BMI, having had a previous fragility fracture, experiencing early menopause, lifestyle factors like low calcium or vitamin D intake, high caffeine intake, smoking, excessive alcohol, being sedentary, and certain medications, especially corticosteroids, and some diseases like rheumatoid arthritis can also increase risk.
Okay, that's a lot to consider for bone health. Now, the heart, that's another major concern, right?
Absolutely. The risk of cardiovascular disease increases significantly after menopause, and again, that drop in estrogen is a key factor. Estrogen has several protective effects on the cardiovascular system. It helps increase HDL cholesterol, the good kind, especially a subtype called HDL2. It also helps lower LDL cholesterol, the bad kind, and total cholesterol. It inhibits platelets and certain immune cells from clumping together and forming plaques in the arteries.
It sounds like it helps keep blood vessels healthy.
Exactly. It stimulates the production of substances like nitric oxide, which helps blood vessels relax and widen, improving blood flow. It also has antioxidant properties that help prevent atherosclerosis, the hardening of the arteries.
So losing that protection after menopause is a big deal.
It is. And when combined with other cardiovascular risk factors that might also increase with age, like hypertension, smoking, high cholesterol, diabetes, or impaired glucose tolerance, it really elevates the risk for conditions like ischemic heart disease, coronary artery disease, and stroke.
Okay, so for many people, the very first clue something is changing is actually their period. What are the typical patterns someone might see leading up to menopause?
You're right. Changes in menstruation are often the first sign. It's actually quite rare for periods to just stop abruptly one day. More commonly, women notice a gradual change. Maybe the flow becomes lighter or the duration shorter. They might start spotting between periods, or cycles become delayed, farther apart, before eventually stopping altogether.
What about irregular bleeding, like heavier periods?
That's another common pattern in irregular cycles, sometimes with episodes of unusually heavy bleeding. Though it's really important to stress that any irregular or heavy bleeding, especially around this time of life, should always be checked out by a doctor to rule out other potential causes, like fibroids or, more rarely, malignancy.
Okay, good point. But beyond the period changes, What are the really characteristic symptoms people often talk about, the ones that can really impact daily life?
Well, it's interesting. Apart from periods stopping, a significant number of women don't actually experience many other bothersome symptoms. But for those who do, the symptoms can fall into several key categories. We've talked about the long-term risks like osteoporosis and cardiovascular disease, but the more immediate symptoms often include vasomotor symptoms, urogenital atrophy symptoms, psychological changes, skin and hair changes, sexual dysfunction, and sometimes cognitive issues.
Let's unpack some of those vasomotor symptoms. What exactly does that mean?
The classic vasomotor symptom is the hot flash, or sometimes called a hot flush. It's that sudden, intense feeling of heat, usually starting in the chest and face, spreading through the body. It's often followed by profuse sweating as the body tries to cool down.
Right, I've heard people describe it like an internal furnace kicking on.
Exactly. And it can come with palpitations, feeling weak or fatigued afterwards. They typically last anywhere from 1 to maybe 10 minutes, and for some women, they can be incredibly disruptive, especially at night.
Night sweats, right.
Yes, night sweats are just hot flashes that happen during sleep, and they can seriously mess with your sleep quality. Physiologically, what's happening is complex, but basically, the body's internal thermostat, located in the brain, gets destabilized by the fluctuating and low estrogen levels. Neurotransmitters like norepinephrine and serotonin are involved. The brain essentially thinks the body is overheating even when it's not, and triggers these mechanisms: vasodilation, widening blood vessels near the skin, and sweating to cool down. It seems to coincide with pulses of GnRH and LH from the brain, too.
Fascinating. Okay, and you mentioned urogenital atrophy and sexual changes. We touched on the physical changes earlier, but how does that translate into symptoms?
Right, so that thinning and drying of the vaginal and urinary tissues due to low estrogen, that's urogenital atrophy, leads directly to symptoms. Vaginal dryness is very common, leading to discomfort, itching, and painful intercourse, or dyspareunia. The tissue is more fragile, so even minor friction can cause spotting or bleeding. It's also more prone to infections. Urinary symptoms are also frequent, feeling like you have to go urgently, pain or burning with urination, dysuria, recurrent UTIs, and that stress incontinence we mentioned.
And sexual dysfunction, is that just the pain aspect?
It's often multifactorial. Decreased desire or libido is common. That can be partly psychological, related to mood changes, sleep disruption, body image concerns, but it's also directly linked to the physical discomfort from vaginal atrophy. It's hard to feel desire when sex is painful.
That makes sense. What about the more subtle changes? Skin, hair, psychological shifts?
Yeah, these can be equally impactful. With lower estrogen, the skin tends to become thinner, drier, less elastic, and more prone to wrinkling. Collagen, which gives skin its structure and plumpness, decreases by about 1–2% per year after menopause. You might notice characteristic lines like purse string wrinkles around the mouth or crow's feet around the eyes.
Because estrogen receptors are in the skin.
Exactly, especially if facial skin has a lot of them. So hormone therapy can sometimes help mitigate these changes. Hair can also thin, you might lose some pubic or underarm hair, and sometimes slight balding occurs that's thought to be the effect of relatively normal testosterone levels now acting without as much opposing estrogen.
And the psychological side? Mood swings, brain fog.
Yes, many women report increased anxiety, irritability, trouble sleeping, insomnia, headaches, difficulty concentrating or brain fog, mood swings, and sometimes even depression. Estrogen does play a role in brain chemistry and function, including areas involved in mood and memory. It seems to enhance opioid activity, which can affect mood and pain perception.
What about dementia? Is there a link?
That's a complex area. We know estrogen seems to improve blood flow in the brain and might support cognitive function. However, research on whether hormone therapy prevents vascular dementia or Alzheimer's disease has yielded mixed results, and currently it's not recommended for that primary purpose. There's still more to learn there.
Okay, so if someone is experiencing a combination of these things, period changes, hot flashes, maybe some vaginal dryness, how is menopause actually diagnosed officially? Is it just based on symptoms, or are there tests?
It's primarily a clinical diagnosis, meaning it's based on the overall picture, your age, your symptoms, and especially your menstrual history. The key criterion is that cessation of periods for 12 consecutive months, happening around the typical age range, so average age 50. The presence of characteristic symptoms like hot flashes and night sweats strongly supports the diagnosis.
Are lab tests ever needed?
They can be helpful, especially if the picture isn't entirely clear or maybe if menopause is suspected earlier than usual. A vaginal smear can be examined under a microscope. The cell pattern changes with low estrogen, showing what's called a low maturation index. and blood tests are quite definitive. Serum estradiol will be low, typically less than 20 pgml, while serum FSH and LH levels will be significantly elevated, usually over 40 MI/UML. To be sure, doctors often check FSH-LH levels maybe 3 times over a few weeks.
Okay, so a combination of history, symptoms, and sometimes lab tests confirms it. Once it is confirmed, what are the options? What are the avenues for management? Is it all about treatment, or is prevention part of it?
Well, natural spontaneous menopause isn't something you can prevent. It's a normal life stage. However, if menopause is being induced artificially, say, through planned surgery like ovary removal or due to radiation or chemotherapy, sometimes steps can be taken to prevent or delay that, if appropriate for the medical situation.
But for natural menopause, management is key.
Exactly. And a huge part of management is actually counseling and education. Just explaining what's happening physiologically, addressing fears, reassuring women that it's normal can make a massive difference in minimizing anxiety, depression, or insomnia related to the uncertainty. Knowledge really is power here.
Absolutely. So let's start with non-hormonal approaches. If someone wants to manage symptoms or support their long-term health without hormones, what can they do?
There's quite a lot, actually, focusing on lifestyle and specific non-hormonal medications. Lifestyle is huge. Regular physical activity is key, especially weight-bearing exercises, things like walking, jogging, dancing, lifting weights to help maintain bone density. Reducing things known to potentially worsen symptoms or bone loss is also good, so limiting high caffeine intake, stopping smoking, avoiding excessive alcohol, and ensuring adequate calcium intake through diet, aiming for around maybe 1 to 1.5 grams per day. Think about 300 milliliters of milk has about 300 milligram calcium.
And diet in general.
Just a balanced, nutritious diet with enough protein and ensuring that calcium intake is important. Supplements are often recommended, particularly calcium and vitamin D3. Daily calcium around that 1.5 G mark, and vitamin D3, maybe 1,500, 2,000 IU per day, can significantly help reduce osteoporosis risk and fractures.
And getting some sunlight helps with vitamin D.
Does. Sensible sun exposure helps your body synthesize vitamin D naturally. Exercise, as we said. Weight bearing is great for bones.
Oh, okay. What about specific medications for those who either can't use hormones or choose not to? You mentioned some earlier.
Yes, there are several effective non-hormonal medication options. Bisphosphonates are a major class drugs like alendronate or risedronate. They work by slowing down those osteoclasts, the bone breakdown cells, which helps improve bone density and prevent fractures. They are often preferred for older women.
Are there downsides?
They can sometimes cause gastric or esophageal irritation, so you have to take them carefully, usually on an empty stomach and staying upright for a while afterwards. And importantly, they don't help with hot flashes or vaginal atrophy or cardiovascular protection. Calcitonin is another option that inhibits bone resorption. It's sometimes given as a nasal spray or injection, often if estrogen is contraindicated.
What about SERMs? Selective estrogen receptor modulators.
Right. SERMs like raloxifene are interesting. They act like estrogen in some tissues, but block it in others. So raloxifene increases bone mineral density, which is good, and it can lower LDL cholesterol. It also seems to reduce the risk of certain types of breast and endometrial cancer.
But downsides?
Yes. They generally don't improve hot flashes or urogenital atrophy. They can sometimes even worsen hot flashes. And they do carry a slightly increased risk of venous thromboembolism or VTE blood clots.
Okay. What about specifically for hot flashes, if that's the main issue?
There are options. Clonidine, which is actually an older blood pressure medication, can reduce the severity and duration of hot flashes. It's useful if estrogen isn't an option, perhaps due to high blood pressure, but it can cause side effects like low blood pressure itself, dry mouth, constipation. Certain antidepressants, specifically SSRIs like paroxetine or SNRIs like venlafaxine, have been found to be quite effective for reducing both the frequency and severity of hot flashes. And another medication, gabapentin, which is often used for nerve pain or seizures, also works well for hot flashes in many women.
And any complementary or alternative approaches that have evidence?
Some research suggests benefits. Phytoestrogens. These are plant compounds that mimic estrogen weakly, found in things like soy and flaxseed, are associated with a lower incidence of vasomotor symptoms, osteoporosis, and cardiovascular disease in populations that consume a lot of them. Soy protein itself seems to reduce vasomotor symptoms for some, likely acting like a weak SERM. Vitamin E has also shown some modest benefit, maybe reducing hot flashes by about 25% for some women.
Okay, so a range of non-hormonal strategies. Now let's tackle the big one. Hormone therapy, or HT, used to be called HRT. It's often debated. There's a lot of history and maybe some confusion. Let's get specific. Who is it really for? What are the clear benefits and what are the risks we need to be aware of?
Right, HT is definitely a topic that needs careful discussion. The primary indications are really for relief of moderate to severe menopausal symptoms, especially those vasomotor symptoms, hot flashes, night sweats that significantly impact quality of life. It's also indicated for the prevention of osteoporosis, particularly in women at high risk who can't tolerate other treatments. And maintaining quality of life is a key goal.
Are there specific groups who particularly benefit?
Yes, it's often strongly recommended for women who experience premature ovarian failure, meaning menopause before age 40, or those with conditions like gonadal dysgenesis, or those who undergo surgical or radiation-induced menopause at a younger age. For them, replacing hormones until the average age of menopause is generally advised to mitigate long-term risks.
Okay. What are the main benefits someone can expect if they do start HT?
The benefits for symptom relief can be really significant. HT is the most effective treatment we have for vasomotor symptoms, often providing a 70–80% reduction in hot flashes and night sweats. It's also highly effective for treating urogenital atrophy, relieving vaginal dryness, discomfort during intercourse, and potentially reducing urinary symptoms. For bone health, it increases bone mineral density, typically by 2–5%, and significantly reduces the risk of both vertebral and hip fractures, maybe by 25–50%.
Any other benefits?
There's evidence it reduces the risk of colorectal cancer by about 20%. And while the overall cardiovascular picture is complex, estrogen does have beneficial effects like improving cholesterol profiles, lowering LDL, raising HDL, potentially improving glucose metabolism, and having direct positive effects on blood vessels.
Okay, those are compelling benefits. Now the risks, this is where a lot of the concern lies, especially after studies like the Women's Health Initiative came out years ago.
Absolutely. Understanding the risks is crucial for informed decision-making. A major one is endometrial cancer. If a woman still has her uterus, taking estrogen alone significantly increases the risk of the uterine lining overgrowing, leading to hyperplasia or cancer.
So that's why progestin is added.
Exactly. Adding a progestin hormone for at least 12–14 days each month, or continuously at a lower dose, is essential to protect the endometrium and counteract that risk.
What about breast cancer risk? That's a big concern for many.
Yes. The data, mainly from large studies like the WHI, shows that long-term use, typically more than 5 years, of combined estrogen and progestin HT is associated with a small increase in the risk of breast cancer. The relative risk is often cited around 1.26, meaning about a 26% increase over baseline. It seems to be dependent on the dose and duration of use. Estrogen alone therapy in women without a uterus showed different results, potentially even a slight decrease in risk in some analyses, but it's complex.
Okay, what about blood clots? VTE.
Yes, there's an increased risk of venous thromboembolic disease, deep vein thrombosis, or pulmonary embolism, particularly with oral combined estrogen and progestin HT. Interestingly, transdermal estrogen, delivered through patches or gels, appears to carry a lower risk of VTE because it avoids the first pass through the liver.
And heart disease, CHD.
This is another complex area. The WHI study showed a slight increase in the relative hazard for coronary heart disease, around 1.29, with combined HT, especially when started later in menopause. However, other studies suggest timing might matter, with potential benefits if started earlier, closer to the menopause transition, the timing hypothesis. High blood pressure itself isn't considered a contraindication for HT, but it needs to be well managed.
Any other risks?
There's an increased risk of gallbladder disease, likely due to estrogen increasing cholesterol concentration in bile. And as we discussed, the data on dementia and Alzheimer's is not supportive of a benefit, and some studies suggested no benefit or even potential harm, particularly when started later in life.
Okay, so given these risks, who should definitely not use HT? What are the main contraindications?
The absolute contraindications include known or suspected breast cancer, any undiagnosed abnormal genital bleeding, needs investigation first, known or suspected estrogen-dependent cancer, like endometrial cancer, a history of VTE or active DVT-PE, active liver disease, and known gallbladder disease. Caution is also needed with a history of cholestatic jaundice during pregnancy or previous endometriosis.
Right, so if someone is a candidate and decides to proceed, how is HT typically given? What are the options?
The core component is estrogen. If a woman has had a hysterectomy, uterus removed, estrogen alone is generally the ideal choice. If the uterus is intact, a progestin must be added for endometrial protection.
What types of estrogen and progestin are common?
Common estrogens used are conjugated equine estrogens, CEE, often at doses like 0.625 mg a day, or micronized estradiol at 1 to 2 mg a day. Common progestins include medroxyprogesterone acetate, MPA, maybe 2.5 milligram per day, or micronized progesterone, 100, 300 milligram a day, or dydrogesterone.
And how are they taken? Pills, patches?
Several routes are available. Oral pills are common and convenient. Even low doses like 0.3 milligrams of CEE can be effective with potentially fewer side effects. Transdermal options like patches or gels are increasingly popular. They deliver estrogen directly through the skin, avoiding that first pass through the liver. This means potentially lower risks of VTE and gallbladder issues compared to oral routes. Patches might release around 50 micrograms per day and are changed twice weekly. Gels are applied daily. They also tend to maintain a more physiological ratio of estradiol to estrone.
Any other routes?
Yes, subdermal implants containing estradiol can be placed under the skin, providing hormones for about 6 months. These are usually reserved for women post-hysterectomy. For purely local symptoms like vaginal dryness, estrogen creams applied directly to the vagina are very effective with minimal systemic absorption. This is a great option if systemic HT isn't needed or wanted. You can also use progestins alone, like MPA, which can help with hot flashes and offer some bone protection, especially if estrogen is contraindicated. And another option for endometrial protection when using systemic estrogen is the levonorgestrel intrauterine system, LNG-IUS. A smaller version is available for postmenopausal women, releasing a low dose of progestin directly into the uterus with minimal systemic side effects.
Okay, lots of options. Now, a key question. Duration. How long should someone stay on HT? Is it forever?
That's a really important point. The general consensus now, based on guidelines like those from ACOG, is to use HT for the shortest duration necessary to manage symptoms effectively, using the lowest effective dose. Often this means around 3 to 5 years, but it needs to be individualized. The decision should be revisited regularly, typically annually or semi-annually, through discussions between the woman and her doctor, weighing the ongoing benefits against potential risks for her specific situation.
So ongoing monitoring is key. What does that involve?
Yes, regular checkups are essential. This includes a physical exam, checking blood pressure, regular breast exams, and mammograms as per standard screening guidelines, cervical cytology, pap smears, and sometimes pelvic ultrasounds to assess the endometrial thickness if there's an intact uterus or any bleeding. If irregular bleeding occurs on HT, it always needs investigation. Sometimes doctors might check serum estradiol levels to aim for a therapeutic range, maybe around 100 pg/ml.
Okay. Are there any other notable therapies specifically for menopause-related issues that we haven't covered?
A few others are worth mentioning. Tibolone is a synthetic steroid that has weak estrogenic, progestogenic, and also androgenic properties. It can help with hot flashes, prevent osteoporosis, improve vaginal atrophy, and some find it increases libido. For women specifically struggling with low sexual desire, hypoactive sexual desire disorder, or HSDD, testosterone replacement therapy is sometimes considered, often as a patch or gel. It can improve mood, energy, muscle mass, and libido, but it's generally recommended for short-term use due to limited long-term safety data.
And for severe osteoporosis?
For established osteoporosis with high fracture risk, besides bisphosphonates, there's teriparatide. This is a recombinant form of parathyroid hormone, PTH, given by daily injection. Unlike drugs that just slow bone breakdown, low doses of PTH actually stimulate osteoblasts, the bone-building cells, promoting new bone formation. Its use is typically limited to about 2 years.
What about things like acupuncture?
Acupuncture has shown some promise in studies for decreasing the frequency and intensity of hot flashes for some women. It's considered a complementary therapy.
Okay, so we've covered the typical timelines, symptoms, and management. But finally, sometimes menopause doesn't follow that average path. What are some of the abnormal ways menopause can present?
Right. Abnormal here usually refers to the timing or the cause. Premature menopause, sometimes called premature ovarian insufficiency, POI, is when menopause occurs at or before age 40. This often has a familial link, meaning it can run in families. For these women, hormone replacement therapy is generally strongly recommended, at least until the average age of natural menopause, around 50-51, to mitigate the long-term health risks associated with prolonged estrogen deficiency, like osteoporosis and heart disease.
What about the opposite, delayed menopause?
Yes, that's when menopause fails to occur beyond age 55. Sometimes it's just constitutional, the woman's natural timeline is later. However, it can occasionally be associated with underlying conditions like uterine fibroids, diabetes, or rarely estrogen-producing ovarian tumors. So delayed menopause warrants investigation, often including tests like a diagnostic curettage, sampling the uterine lining, because of a potentially increased lifetime risk of endometrial cancer due to longer estrogen exposure. Sometimes a hysterectomy might be considered if there are related issues.
Okay. And what about menopause that isn't natural at all?
That's referred to as artificial menopause. It's when ovarian function is stopped permanently by artificial means. The most common causes are surgical removal of both ovaries, bilateral oophorectomy, radiation therapy directed at the ovaries, or certain types of chemotherapy that damage the ovaries.
Does surgical menopause feel different?
Often, yes. Surgical menopause, especially when performed on a woman who is previously menstruating normally, leads to a very abrupt drop in hormones. The symptoms, like hot flashes, can onset suddenly and often feel more intense than those experienced during a gradual natural menopause. Radiation menopause can also occur, especially with pelvic radiation. Interestingly, particularly in younger women under 40 receiving radiation, the ovarian suppression might not always be permanent. Menstruation and even conception might sometimes resume after a couple of years. Symptoms from radiation tend to be less intense than after surgery. Wow, okay. So if we try to connect all these threads, looking at the bigger picture, it's really clear that menopause isn't just, period stopping. It's this incredibly complex whole body transition.
Absolutely. Understanding those underlying hormonal shifts, recognizing the systemic impacts on things like bone and cardiovascular health, and being aware of the huge range of potential symptoms, that knowledge really empowers you to navigate the stage proactively and confidently.
And what does this all mean for you, listening? We've seen how much of the timing might be down to your genes, sort of predetermined. Yet, your lifestyle choices, the management strategies you explore with your doctor, these can significantly shape your actual experience. From, the surprising role your own body fat plays in making hormones after menopause, to really understanding the nuanced benefits and risks of different therapies like HT, hopefully. This deep dive gives you a much more robust foundation.
And it really raises a fascinating question, doesn't it? Given that women may now spend a third or even more of their lives in postmenopause, how might a deeper societal understanding, a more proactive, maybe even personalized approach to this entire phase truly transform women's health and quality of life for generations, moving beyond just managing symptoms to actively optimizing well-being throughout the entire second half of life?
That's definitely something to mull over as you integrate all these insights. Thanks so much for joining us on this deep dive today.